Acromegaly is a disorder characterized by growth hormone hypersecretion, multisystem-associated morbidities, and increased mortality. Patients should be queried regarding and examined for typical signs and symptoms of acromegaly, including somatic enlargement, excessive sweating, jaw overgrowth, joint pains, cardiomyopathy, carpal tunnel syndrome, sleep apnea syndrome, osteoarthropathy, diabetes mellitus, menstrual irregularities in women and sexual dysfunction in men, headache, and visual field loss, attributable to optic chiasmal compression, and diplopia, due to cranial nerve palsy. The finding of hypercalcemia should prompt an evaluation for primary hyperparathyroidism and, if present, consideration of multiple endocrine neoplasia type 1. Corrective orthopedic or plastic surgical procedures should be postponed until serum concentrations of growth hormone and insulin-like growth factor I normalize. Performance of a sleep study for evaluation of sleep apnea syndrome, which is frequently associated with acromegaly, should be considered. Although there is insufficient evidence to state that patients with acromegaly have an increased risk of colon cancer, there is evidence of an increased prevalence of colon polyps. Therefore, colonoscopy is recommended. How is a diagnosis of acromegaly made? Clinicians should suspect acromegaly in patients with 2 or more of the following comorbidities: new-onset diabetes, diffuse arthralgias, new-onset or difficult-to-control hypertension, cardiac disease including biventricular hypertrophy and diastolic or systolic dysfunction, fatigue, headaches, carpal tunnel syndrome, sleep apnea syndrome, diaphoresis, loss of the vision, colon polyps, and progressive jaw malocclusion. A random IGF-1 value should be measured for diagnosis and for monitoring after a therapeutic intervention. A growth hormone value 1 nanogram per milliliter after an oral glucose tolerance test, 75 grams of glucose orally followed by growth hormone measurements every 30 minutes for 120 minutes, is considered normal. Once a biochemical diagnosis of acromegaly has been made, an MRI scan of the pituitary gland should be performed because a pituitary growth hormone secreting adenoma is the cause in most cases. Further biochemical testing should include a serum prolactin level, to evaluate for hyperprolactinemia, and assessment of anterior and posterior pituitary function. What are the therapeutic options? The pros and cons of pituitary surgery should be discussed, with emphasis on the value of surgical intervention as the primary therapy in most patients because it is the most effective option for inducing rapid and complete biochemical cure of acromegaly in patients who meet surgical criteria. There is sufficient evidence for recommending pituitary surgery as a primary treatment in patients with microadenomas and in patients with macroadenomas that are associated with local mass effects or are unclosed and potentially curable surgically because surgery can lead to durable control of the tumor mass and associated biochemical effects. In most patients, medical therapy is used as adjuvant treatment in the setting of persistent disease despite surgical intervention. Radiation therapy is recommended as adjuvant treatment in patients with active disease despite surgery and medical therapy or in patients who prefer radiation in light of the cost of long-term medical treatment. Postoperative management should include monitoring for electrolyte abnormalities, including diabetes insipidus and syndrome of inappropriate secretion of antidiuretic hormone, for up to 2 weeks. In the postoperative setting, the presence of diuresis may reflect obligate natriuresis after a rapid reduction in growth hormone and IGF-1 values. A serum IGF-1 level should be remeasured at 12 weeks. A normal IGF-1 value is consistent with surgical remission. A repeated OGTT may be performed at 12 weeks. A growth hormone value 1 nanogram per milliliter is consistent with surgical remission. Repeated imaging with an MRI scan should be performed at 12 weeks after surgery to assess for residual tumor and establish a postoperative baseline. Repeated pituitary hormone testing, including the thyroid and gonadal axes, should be performed at 6 to 12 weeks postoperatively in order to assess pituitary function and the need for hormone replacement therapy. There are three classes of medical therapy: dopamine agonists, somatostatin analogs, and a growth hormone receptor antagonist. There are two dopamine agonists, cabergoline and bromocriptine, available for patients in the United States. Dopamine agonists may be considered as first-line medical therapy because these agents are orally administered and relatively inexpensive in comparison with the other medical therapy options. There are two long-acting, depot somatostatin analogs available: octreotide LAR, long-acting release, administered as an intramuscular injection, and lanreotide autogel, administered as a deep subcutaneous depot injection. Somatostatin analogs are effective in normalizing IGF-1 and growth hormone levels in approximately 55% of patients. In patients with an inadequate response to somatostatin analogs, the addition of cabergoline or pegvisomant may be effective for further lowering of growth hormone or IGF-1 levels. Pegvisomant is a growth hormone receptor antagonist that competes with endogenous growth hormone for its receptor and prevents functional dimerization and signal transduction by the growth hormone receptor. In a pregnant patient with acromegaly, biochemical monitoring with measurement of growth hormone or IGF-1 levels is of limited use.